Good afternoon, late afternoon. Good afternoon, everybody, and welcome. It's Fertility Talk, and today we're talking to Barth. And Barth is from a company called Repro Lab. So thank you, Barth, for joining us. Thank you for taking time out to do this talk. You're just telling me how busy you are and how you've been rushing around all day. So we really appreciate this. So today we're talking about tests and assessments, diagnosis when it comes to male infertility. So please, first of all, thank you for joining us. And then please tell us what it is that you do and who you are, where you're from.
Thank you, Lee. As Lee said, my name is Barth, and I'm embryologist based here in Centurion, Pretoria. I own Repro Lab, which is an andrology laboratory, but we also work into human IVF with family matters and different clinics of around the town of Pretoria. Yes.
Okay, awesome. Thank you. So we've got a few questions for you, Barth, and the first one is, explain the diagnostic process for male infertility.
Thank you very much for the question. Okay. One thing that we need to know is that the ability to diagnose and treat infertility is advanced in the past decade. So it's very important to be able to do a proper and complete diagnostic before we can give any treatment to the patient. And because we are talking about reproduction, it takes two to tango. So both partners need to be tested simultaneously to make sure that wherever the problem is, it can be picked up. Fertility status of one partner can also influence the other partner. So the first thing that we're going to do, it will be just to take a history of the patient, the male history, okay? Things like age, we need to know the age of the patient and for how long they've been struggling with infertility, how many relationships the person has been in, and was there any pregnancy or no. Those are a few things that we need to know. But we need also to go into medical history, which is based on the reproductive tract. That can be the genitals, including the urinary system and all the pelvic. So we need to ask the patient things like, was there a past history with cryptorchidism, for example, or was there any trauma or any cancer, or at the level of the testicles, was there any torsion? These are the type of question we need to ask the patient. And the patient needs to be really aware of what he went through so that we can see at what angle we can go and assist the patient. Because infertility is such a wide space, and we don't need to waste a lot of time. But if we have a proper history, another thing that we ask the couple, for example, is the sexual habits. How often do they have sex? Because we know the female cannot fall pregnant every day. We need to find out if they have a knowledge of ovulatory cycle, for example, and then to know when is the right time to have intercourse or no. Also, we have sometimes couples use some spermatotoxic agent like saliva, like lubricant during intercourse, and this can affect the fertility. So these are the few things that we need to go through. But we need also to get the social history of the patient. Does the patient take cigarette or marijuana? Because it's been shown that smoking can reduce the density of the sperm, the motility, and the morphology of the sperm as well. We have people who are into bodybuilding using metabolic steroids, okay? And these elements can lead to hypogonadism or change the structure of the sperm itself. Alcohol can increase the concentration of testosterone into the blood, and we know what testosterone is responsible of. Also, excessive heat can affect the sperm quality temporarily. So these are a few background we want to ask a patient and to see if whether is anything that can come across. After the history, now we're going to physical. And into physical examination, we take the patient into the room where the patient needs to be relaxed and the room needs to be a bit warmer. And then we're going just to check the pelvic area, also check on the level of the testicles first. We check, are the testicles present? Are they of almost the same size? Are they sliding in the scrotum? Those are the type of things we check. We check for the epididymis, we check for the vas deferens, it's present or no. We check for lumps, which can bring blockage into the pipe in the system that release sperm outside. But also we check the opening of the urethra, which is the hole that is in front of the penis where the sperm is ejaculated. Sometimes you have a position that we call hypospadia, that the opening of the urethra can be below the penis or can be up on top of the penis, and that can be a serious problem because semen is not going to be deposited at the correct place, which is the opening of the cervix.
Okay, thank you, Barth. And then the next question is, share with us various test assessments for male infertility.
Okay, assessment is very simple for the men. We know we have our standard with semen analysis. That will be the first things to do. It's such a straightforward and simple test where we're going to check the volume of the semen, for example. Normal volume should be from 1.5 ml and above. And if we have a small volume lower than 1.5, it can be an indication either there is a retrograde ejaculation or the man is suffering from an ejaculation in case of a spinal cord injury, for example. We're going to look also at the number of sperm per milliliter. We're going to check the shape of the sperm, the motility of the sperm, and we can even go further check the DNA of the sperm, whether it's intact or not. Those are a few things that we can do. And if, for example, the semen analysis come out normal, but still the patient are struggling. So what normal is not normal when the patient doesn't have the baby that they want.
Yes.
So although the sperm comes out, the analysis show that everything is normal, we need to do further tests that we call sperm function test. We want to check and see, is the sperm capable for accomplishing the function that it's supposed to? And then we're going to check, for example, sperm longevity, just to say once it produces, how long does it last before they stop moving, okay? Because we know into a human body, female body, the sperm can last up to 48 hours, going even to 5 days. But once we have sperm and after 2 hours, they stop moving, that can be already an indication in terms of sperm function. We have another test that is called acrosome reaction test. Acrosome is it's like a cap that covers the sperm head. It covers almost about 40 to 60% of the sperm head. And this cap is responsible for sperm to attach to the egg and penetrate the egg until the genetic material will be deposited into the egg. We need to check that cap is functional. Is it doing its job? Wow. We can also do the zona pellucida test. We can do in case, for example, sperm is not moving, we want to know whether the sperm is alive or they are dead. Then we have a test that we call hypoosmotic swelling test. Okay, that test will allow us that sperm is not moving, is still alive or not. We can also do other number of tests just to be able to help our patient. And then from there, we should be able to see what is the problem, okay? And then after semen analysis, we need also to check the hormones because hormones are chemicals that allow the body to function. And in this discussion, we're looking at how hormones can help the body to produce sperm, can help the body to be in the mood for sex and ability to have sex as well. So we have a couple of hormones like FSH, which has been shown to help with spermatogenesis. We have LH, which help to instruct the testes to produce testosterone, which is very important. We have also prolactin. But if prolactin is too high in the man's blood, it affects your FSH, the LH, and the all other hormones, and they bring about the fertility down. So these are a few tests we can do to be able to see at what level the infertility state and see how we can help the patient.
Wow, it's quite a lot of tests that can be done, and you don't realize, you're just thinking they're just going there, you're giving a man is just giving the cup and it's just do one test, oh no, it works or it doesn't. But now you're saying there are so many tests available, so many things that can be checked. So it leads to the next question. Our last question is, how do results guide treatment options?
Okay, we need to remember through our discussion, we assume that the female partner is okay.
Yes.
Okay, she's ovulating regularly, she have a reserve is okay, everything is not a problem. So we look at the male side. Once, for example, the sperm come out, the semen analysis come out and it's positive, meaning the male sperm doesn't show any problem. We have a couple of things that we can do. First one will be just give supplement. It doesn't kill, to make sure that if there is any problem in the body, it's solved. But the first things that we do home plan, for example, where home plan is a time intercourse. So the gynae or the fertility specialist is going to follow the woman through the cycle. And when it's ready, they will be instructed to have intercourse. And that will be done maybe between 2 to 3 times. If it doesn't work, we can move to sperm wash. So here now, it's at the lab level, the male partner comes, produce sperm sample that we're going to wash. Why we are washing? Because we want to discard everything that is unwanted cells, the luggage sperm, and to remove the content of the semen so that we can have a pure concentration of motile sperm that we use for insemination. That is another thing that we can try, but ultimately, if it doesn't work, we go to in vitro treatment. But this also will depend on the age of the couple. If they are young, we can give them quite enough time to try on themselves and see the outcome. But if they are quite old, then time is not on our side, then we'll try to rush into serious treatment that can be able to help them. That is the first situation if we have all the parameters, semen parameters are okay. Secondly, if, for example, we have a case of azoospermia, it means there is no sperm.
Yeah.
So if there is no sperm, we can have 2 situations. The first situation is called non-obstructive azoospermia, meaning there is no sperm, but there is also obstruction into the piping. So that can be a problem that spermatogenesis is not happening. In this type of people, we can try a testicular biopsy and see whether we can get sperm there. But the patient needs to be advised in advance that the chances of getting sperm is quite rare. And if we don't get any, then we can suggest such couple to consider sperm donation or third-party reproduction. The second type of azoospermia is obstructive azoospermia. So meaning the patient doesn't produce sperm because there is an obstruction in the ducting system, okay? And if that's the case we have, definitely we can help with testicular biopsy or sperm aspiration. Go to the testicle or into the epididymis, aspirate, we should be able to get sperm there. And that sperm can be used with in vitro treatment or intracytoplasmic sperm injection to help the couple. That procedure can definitely be done. In case of retrograde, let's say the patient is suffer from retrograde ejaculation, meaning the ejaculation itself is an antegrade process. So sperm comes from backward going forward. But we have a case where the patient is suffering retrograde. It means the bladder has a kind of a door that needs to close when sperm pass. But if it becomes defective, it means it's open. So instead of semen coming out, the semen is going back into the bladder. And then the patient will feel like he's ejaculating, but it's kind of a dry ejaculation because the semen doesn't come out. So if that's the case, what we do is we ask a patient to masturbate, and after orgasm, they urinate into the containers. We're going to take that urine and check in the urine. We're going to spin the urine, and if there is a sperm, it will go at the bottom of the tube, which we can rescue. And that sperm can be, and that sperm can be used to fertilize the egg, can be used to do artificial insemination, can also be used for IVF. So those are the third treatment that we can give. The third one will be in case of paraplegic patient. This is a patient where the spinal cord is affected and they are not able to ejaculate. In this case, we can use vibration. I've got something here for you, like this guy. I don't know if you can see it.
Yes,
it's
yes,
a
yes.
It's a vibrator. I have it for the past like 4 years, but I use it only once on a paraplegic patient.
Wow.
And it took about 30 to 40 minutes, but we got sperm. Semen ejaculated, and the sperm was washed and frozen and used for the patient. So the other step will be we have sperm, but sperm is abnormal because maybe motility, maybe the count is low, or the shape, which we call morphology, is low. If that's the case, then the couple is young, we can maybe consider sperm wash if we can end up with enough sperm. But afterward, if the sperm wash or insemination doesn't work, we ultimately go into in vitro treatment. Because with in vitro treatment, we are able to separate, to get quite a few quantities of sperm that are good quality. Under the microscope, we can select and see which sperm is viable, which is injected in the egg. This is the way we can do to help a patient who have sperm, but the sperm is abnormal. And if in any case we cannot get sperm, then we have a third-party reproduction where donor sperm is available. The patient needs to be counseled so that they understand the implication. The father who is involved, it will be biological, it will be legally will be the father of the child, but biologically, because this is not his DNA, it's not going to be identical, but the patient or couple need to go through counseling so that they understand what the implications are. And now the last type of treatment we can do is also in vitro treatment with PGTA, pre-implantation genetic diagnosis, where we can diagnose any abnormality. So we are producing the embryos, and around day 5, a piece of the embryos is cut and sent to the lab for further investigation. So that test can show whether there is abnormality in the embryo or no, and only euploid embryos who have good quality can be used for transfer. So this is a few techniques or treatment we can offer patients who are struggling with infertility. And in this case, we are talking about male infertility.
Awesome. Wow. Thanks, Barth. That has been so very insightful. And it's quite a lot of information. So thank you very, very much for that. I mean, it's obviously stuff again that I haven't heard before. I mean, we've done how many talks already now, Barth, on male infertility, but it's like every time we're talking, it's like something new, and I'm like, wow, oh wow, they can do that now. So it just shows you how things have advanced over the years and how much it's still advancing. So thank you very much for taking time out to do this talk with us. Barth, if you could just give us some idea of what, if they want to get a hold of you, if they are dealing with male infertility and they'd like to get a hold of you, how can they get hold of you?
Okay, we have a different platform. The first one is our contact number. It's 073 66 971. Patient can email us at info@reprolab.co.za. We are on Facebook as Repro Lab, Repro Space Lab. We are on TikTok as well as Repro Lab. And they will find us also on Instagram. It's Repro Lab _Repro_Lab.
Okay, perfect. Thank you very much, Barth, for that. And we hope to see you again. I think it's on the 29th. We've got another talk planned. So we'll see you then. We're going to be talking about the genetic side of male infertility. Is that correct?
That's correct, yeah. And we are looking forward to discuss that for the benefit of our patients.
Awesome. Thank you very much, Barth. Have a great evening, and thanks for the talk.
Thank you very much. I will appreciate it. Thank you. Thank you to Fertility Solutions for the opportunity.
Thanks, Barth. Bye.